Hello, my name's Simon Mellor. I'm a consultant orthopaedic surgeon for Total Orthopaedics. I specialize in hip and knee surgery, and today I'm delighted to be able to talk to you about meniscal and patellar conditions of the knee. I thought I'd split this up simply into the meniscal conditions first, and so with no further ado, I thought it would be worthwhile briefly reminding you about the anatomy of the menisci. The shock absorber cartilages of the knee, as it were, are made up of collagen fibers, which are orientated circumferentially to allow hoop stresses to be accommodated. They are embedded in an extracellular matrix, which has proteoglycans and other complex molecules. Quite a lot of water content, and of course there are some cells within the meniscus, fibrochondrocytes, and we are well aware of the function of the meniscus to help spread load between the femur and the tibia and reduce contact pressure points. The meniscus works well from this point of view, but we are well aware that the meniscus does not respond well to damage. And part of the reason for that is the lack of a good blood supply. The peripheral part of the meniscus, just on the very outer edge where it is close to its capsular attachment, has a relatively good blood supply, that outer third of the meniscus, but the central third and the inner third of the meniscus have a poor blood supply, and the diagram displays some of that information for you. In terms of the function of the menisci, they do differ between the medial and the lateral side. The medial meniscus is a larger C-shaped structure. It's quite firmly adherent, held in position by its tethered attachments. And as a result, when you lose your ACL, the medial meniscus does become one of the primary stabilizers of the knee. The lateral meniscus, in contrast, is smaller, more circular in shape, and much more mobile. In deep flexion, the meniscus actually falls off the back of the tibia because of that mobility. The function, as we discussed, is to do with force transfers, and as a shock absorber, the meniscus is a more elastic structure than the articular cartilage, and therefore helps to avoid articular cartilage damage. And we recognize it's the meniscal role in stability as well. Meniscal tears are a common pathology both within the physiotherapy or osteopathy clinic, sports injuries clinic, and indeed within secondary care in the orthopaedic department. And although this is not a hard and fast rule, it's quite easy to separate meniscal tears into two separate age-related subgroups. We tend to see torn cartilages in the sporty young population, and these tears are often as a result of a aggressive pivoting injury in what was otherwise normal meniscal tissue. And then in a separate subgroup, we see meniscal damage in people really above the age of about 40. Just if we look at a cross-section of MRI scans of people above the age of 40, even between 40 and 50, there is a significant percentage of people who will display meniscal pathology, which is obviously non-traumatic in nature and actually not symptomatic either. And we know that meniscal tears are more prevalent in patients who have an otherwise unstable knee, for example, after ACL injury. Now, the easiest thing to remember from this talk, and probably the most worthwhile thing to remember, is how age has a significant impact in terms of potential management of meniscal tears. In basic terms, about 3/4 of young people with a torn cartilage are going to need to have surgery in order to resolve their problem, whereas 3/4 of people above the age of about 45 who have a torn cartilage do not need surgery. And I'll explain briefly why that is. Essentially, the population over about 40, specifically delamination and therefore horizontal cleavage tears of the meniscus are just very prevalent in the normal population. And if you look at percentages, you can see that painful knee in a 50-year-old will often reveal evidence of a meniscal tear, but even in the absence of pain, about the same percentage of people will have a meniscal tear. And therefore, the obvious conclusion is that those people with a meniscal tear, the tear does not necessarily correlate with pathology and therefore does not correlate with the requirement for surgery. In the younger population, there's a much higher instance of radial tears and indeed bucket handle tears, and this is why the younger population are more likely to require surgical intervention. The diagram here shows a representation of all the different types of meniscal tears that we might see, and of note, the longitudinal and flap tears and parrot beak tears are more likely to cause intrusive symptoms. The horizontal cleavage tear and just a degenerative tear with the fraying of the inner edge of the meniscus is not going to be so likely to cause symptoms. The most troublesome meniscal tear, obviously the one diagram in the bottom that shows a bucket handle tear. This is a large vertical longitudinal tear, which results in displacement of a large piece of meniscal tissue from its resting position and displacement into the intercondylar notch. And it's this process which results in potential for locking of the knee. So we can run through a quick case history to illustrate this point. A 23-year-old male football player, whilst playing, has a twisting injury on the planted knee. The fairly typical scenario with a meniscal tear is that the patients will have a pain immediately. They may feel a pop or a snap, but often they'll find that the symptoms aren't that bad, and they'll try and soldier on and carry on playing. The adrenaline's flowing freely through their bloodstream, and they'll see if they can just run it off. But will often be aware of intrusive symptoms, and in fact, eventually will have to limp off the pitch. Usually swelling after a meniscal tear is gradual in onset. This is inflammatory fluid that builds up over the course of the next 12 to 24 hours. And that's in contrast to the history of someone with an ACL tear, where you'll often see somebody having a significant injury and fall down and not be able to stand up afterwards, not be able to continue playing, and usually the swelling is present even within half an hour or so. A lot of people with a simple meniscal tear will be limping for 3 or 4 days, and even minimal twisting will be painful. And occasionally, as with the bucket handle tear, if a large meniscal fragment is displaced out of position, it can result in locking of the knee. Now, we have to be careful about what we describe as locking of the knee. By definition, true locking of a knee means that the knee is held in one position, and in the orthopedic circles we usually describe true locking as implying that the knee is unable to extend beyond a certain blockage point, whereas flexion may still be retained. So for example, somebody that attends the casualty department or the fracture clinic with a knee injury, and as a result of the injury they now have a knee that will not extend beyond 20 degrees of fixed flexion deformity, but they can flex the knee maybe up to 100 or 110 degrees. That would be suggestive of a displaced meniscal fragment resulting in blocking of the knee. This is just a diagrammatic and photographic representation showing a bucket handle tear and how it can flip underneath the spherical surface of the femoral condyle and then jam into the intercondylar notch, and this is what results in that locking. And these sort of patients really should be managed in the urgent processes, so that they get admitted through to a appropriate fracture clinic or an urgent knee clinic, because it's particularly the younger age group that suffer this sort of problem, and it's this particular age group where potentially early meniscal repair surgery may well salvage the situation.